This is a sleep review for the PMHMP ANCC exam, and it's a recap from the PMHMP Review and Resource Manual 4th edition. This chapter addresses sleep issues and disorders commonly encountered by the PMHMP. These conditions and clinical problems may co-occur with the disorders already discussed, or they may present in clients with no identifiable psychiatric or mental health problem. They also may be frequent findings in primary care settings while working with clients with general medical conditions. General medical conditions must be systematically assessed. Comparison of present level of sleep to historical baseline can be measured by polysomnography. Rapid eye movement, or REM, alternating with 4 distinct non-rapid eye movement stages, NREM. Stage 1 is NREM, or non-rapid eye movement. It's a transitional stage from wakefulness to sleep, and it totals 5% of the total normal sleep cycle. The second stage of sleep is also NREM, and it has specific electroencephalogram, or EEG, waveform changes, and it is 50% of total sleep cycle. Stage 3 and 4 of sleep are NREM, and it's slow wave sleep period that is the deepest level of sleep, and it is 20 to 25% of the total sleep cycle. The sleep stages are organized and sequential during the sleep period. Stages 3 and 4 tend to occur in the first 1/3 to 1/2 of the sleep period. REM sleep occurs cyclically throughout the night, alternating with NREM, on average every 80 to 100 minutes. REM sleep increases in duration toward the morning time. Sleep patterns vary with age. Children and adolescents have large amounts of slow wave sleep. Sleep continuity and depth decreases with age. Consider age when assessing for sleep-rest problems. Sleep patterns vary with medication use. Many medications and agents of abuse affect the sleep cycle. Assess recent changes in medication or drug use in a person presenting with sleep pattern disturbances. Insomnia is the inability to get the amount of sleep needed to function efficiently during the day. Situational or acute insomnia lasts from days to weeks. Insomnia disorder is characterized by a significant inability to initiate or maintain sleep, or early morning awakening with the inability to return to sleep, and occurs at least 3 nights per week and is present for at least 1 month, which is episodic insomnia disorder, and it also may persist for greater than 3 months, which is persistent insomnia disorder. Insomnia disorder is associated with increased mortality, poor career performance, and overeating, and increased hospitalization. Insomnia disorder is not better explained by or occurring exclusively during the course of another sleep disorder, and is not attributable to the effects of a substance. The etiology of insomnia. There is dysfunction in the sleep-wake circuits of the brain stem. Neurochemical imbalances impinging on these circuits may be stress-related in brief episodic insomnia. Incidence and demographics. 33% of Americans have difficulty sleeping. Up to 10% meet criteria for insomnia disorder. Insomnia is highly comorbid with other psychiatric disorders. Risk factors are female gender and advancing age, past history of insomnia, significant stress, forced pattern changes such as working alternating shifts or traveling across time zones. There's also genetic, which is an example would be obstructive sleep apnea. Other risk factors are high use patterns of medications, drugs, or substances known to affect the sleep cycles. For example, caffeine, other stimulants, alcohol, and benzodiazepines. Prevention and screening. At-risk family education for children and adolescents. Limits on shift work. Avoidance of medications known to affect sleep patterns. Good sleep hygiene patterns. Avoidance of stimulants late in the day. Early recognition, intervention, and initiation of treatment. Routine screening at all healthcare settings. Assessment. A detailed history of present insomnia, including time frame progression and associated symptoms. Social history, including living in present situation, and so on. Medication use, initial and periodic functional history, functional assessment, number of hours and usual sleep pattern. number of hours in usual sleep pattern, initial or middle insomnia or early morning awakening, use of sleeping pills, bed position, the use of pillows, and environment such as the temperature, sound, and light. Hypersomnolence disorder, self-reported excessive sleepiness despite adequate main sleep period, difficulty being fully awake or groggy after abrupt awakening, occurs at least 3 times per week and lasts for several months, causes significant distress or impairment, not better explained by another sleep disorder, viral infection, or physiological effect of a substance. Hypersomnolence disorder may occur within 18 months of experiencing a head trauma. Comorbidity includes various depressive disorders such as major depression with atypical features, seasonal affective disorder, and bipolar disorder depressed state. Obstructive sleep apnea. The hallmark of the disorder is snoring and repeated apnea during sleep. Daytime sleepiness or a sense of feeling unrefreshed despite adequate sleep period is prominent. Headache upon awakening is common. Consequences of obstructive sleep apnea include panic attacks, waking up gasping, ADHD, depression, hypertension, and vehicle accidents at work. It affects 2% of children and up to 15 to 20% of adults. The etiology of obstructive sleep apnea is due to abnormally small nasopharynx, tonsillar tissue in children, and obesity. Polysomnography to make a definitive diagnosis. Physical exam findings are nonspecific. Sleep disturbance often a manifestation of an underlying disorder. Clients in whom a sleep disorder is suspected should have a full exam. Mental status exam findings. They may have preoccupation with or excessive worry about not getting enough sleep. And depending on the duration of sleep deprivation, many areas of the MSC may be affected. Diagnostic and laboratory findings. CBC, chem profile, thyroid function, and a ferritin level if there's restless legs. A ferritin level if there is restless legs. B12 and B12 to rule out metabolic causes or unidentified conditions. And drug toxicity screening if indicated by history. Differential diagnosis. More than 50% of insomnia cases are related to a primary psychiatric disorder, such as mood disorders, anxiety, substance abuse, and there is a long list. Included in this list are parasomnias, cardiac illness, chronic pain, stress reaction, substance use, drug use, caffeine, and stimulants. Clinical management. Rule out or treat any conditions that may contribute to the current symptom manifestation. Weight loss and avoiding supine sleep positions may alleviate sleep apnea. Positive airway pressure or CPAP or bilevel BiPAP for OSA. Pharmacological management. Melatonin is particularly useful to correct sleep onset issues and may be helpful for the person with ADHD. That's melatonin, sleep onset issues, and ADHD. Benzodiazepines or hypnotics should not be used in OSA. Flurazepam, Dalmane, is a long-acting agent. Flurazepam is a long-acting agent and may cause excessive drowsiness, so avoid in older adults. Avoid flurazepam in older adults. Temazepam is Restoril. It's an intermediate acting agent. Temazepam, Restoril, is an intermediate acting agent. Triazolam, Halcyon, is a short-acting agent, little to no excess sedation. Common side effects are impaired memory. Efficacy decreases over time and should not be used on long-term basis. And that's triazolam. Should not be used on a long-term basis, and common side effects are impaired memory. Non-benzodiazepine hypnotics. Zolpidem is Ambien. It has a short half-life, but may affect a person the next morning. Must allow for 8 hours before planning a planned awakening. Give on an empty stomach. Ezopiclone, Lunesta, is an intermediate acting agent. Rosurum is a melatonin receptor agonist. Suvorexant is Belsomra. It's an orexin antagonist that suppresses wakefulness. Must consider its long half-life. Antidepressants are sometimes used for their sedating properties. There's amitriptyline, which is Elavil, doxepin, which is Sinequan or Silanor. Generally avoid TCAs in older adults. So, more antidepressants that are used for their sedating effects are mirtazapine, which is Remeron, and trazodone. Wake-promoting drugs are armodafinil, which is Nuvigil, which is indicated for daytime sleepiness associated with OSA. Non-pharmacological management. There's sleep hygiene practices such as establishing a bedtime routine, regular sleep and wake times, avoid computer or electronic devices 1 hour before bed, never lie in bed for more than 15 minutes if not able to sleep, reduce stress, do stress reduction activities before bed, avoid late in the day intensive exercise or stimulant use such as caffeine, use the bedroom for sleep or sex only, consider moving the phone and other devices away from the sleeping area, psychotherapy and cognitive therapy for insomnia. Relaxation and other therapies. There's abdominal breathing, progressive muscle relaxation, meditation, imaging, hypnosis, biofeedback, stimulus control, sleep curtailment, and light therapy. Somatic and other therapies are exercise during the day, warm bath, warm milk, and change the bedroom environment. Lifespan considerations. Insomnia in children is most commonly related to stress. Children with insomnia often have been poor sleepers since birth. Pharmacological treatment is not recommended for most children. Insomnia in older adults. If their first presentation is in the older years, insomnia is often the result of changes in chronobiological rhythms. Older adults often become sleepier earlier in the evening and wake up early. Sleep, there is sleep latency, decreased REM sleep, and increased sleep fragmentation. Insomnia may be related to underlying psychiatric disorders, such as mood, anxiety, attention, hyperactivity, and Alzheimer's disease. Older adults often manifest confusion and restlessness as aspects of insomnia. A careful, complete assessment is necessary when pharmacological interventions are planned. This wraps up the sleep presentation, and the last presentation to conclude recapping this book is Chapter 17, and it is about violence.